Okay, patients with history compatible with myocardial ischemia requiring an urgent 12-lead ECG, acute chest pain with ECG, changes including indicating an ST segment elevation, myocardial infarction STEMI suggests that the patient is likely to benefit from immediate reperfusion therapy. Specific information relating to cocaine or amphetamine use should be sought, particularly in younger patients. In the context of a compatible history, an ECG showing ischemic changes that do not meet STEMI criteria should prompt regular repeat ECGs and treatment for non-ST segment elevation, myocardial infarction, or unstable angina. Measurement of serum troponin concentration or admission is often helpful in cases where there is diagnostic doubt, but a negative result should always prompt a repeat sample 6 to 12 hours after maximal pain. Acute coronary syndrome may be diagnosed with confidence in patients with a convincing history of ischemic pain. Acute coronary syndrome may be diagnosed with confidence in patients with a convincing history of ischemic pain and either ECG evidence of ischemia or an elevated serum troponin. If an elevated serum troponin is found in a patient who has an atypical history or is at low risk of ischemic heart disease, then alternative causes of raised troponin should be considered. Further management of acute coronary syndromes is discussed on page 434. In the absence of convincing ECG evidence of myocardial ischemia or other life-threatening causes of chest pain, such as aortic dissection, massive pulmonary embolism, and esophageal rupture, should be considered. Suspicion of aortic dissection, background of hypertension, trauma, pregnancy, or previous aortic surgery. Hypertension, trauma, pregnancy, or previous aortic surgery should prompt urgent thoracic computed tomography or transesophageal echocardiography, and ECG in the context of massive pulmonary embolism most commonly reveals only a sinus tachycardia but may show new right axis deviation, right bundle branch block, or a dominant R wave in V1. The classical findings of S1, Q3, T3. A deep S wave in lead 1 with a Q wave and T wave inversion in lead 3 is rare. The classical finding of S1, Q3, T3, a deep S wave in lead 1 with a Q wave and T wave inversion in lead 3 is rare. If massive PE is suspected and the patient is hemodynamically unstable, a transthoracic echocardiogram to seek evidence of right heart strain and exclude alternative diagnosis such as tamponade is extremely useful. Causes of elevated serum troponin other than acute coronary syndrome. Cardiorespiratory causes. Pulmonary embolism, acute pulmonary edema, tachyarrhythmias, myocarditis or myopericarditis, aortic dissection, cardiac trauma, cardiac surgery or ablation. Non-cardiorespiratory causes. Prolonged hypotension, severe sepsis, severe burns, stroke, subarachnoid hemorrhage, end-stage renal failure. If a patient is deemed to be at low risk of pulmonary embolism, a D-dimer test can be informative as a negative result effectively excludes the diagnosis. The D-dimer test should be performed only if there is a clinical suspicion of PE, as false positive results can lead to unnecessary investigations. If the D-dimer is positive, there is high clinical suspicion or there is other convincing evidence of pulmonary embolism such as features of right heart strain on the ECG. Prompt imaging should be arranged. Acute breathlessness. In acute breathlessness, the history along with the rapid but careful examination will usually suggest a diagnosis that can be confirmed by routine investigations including chest X-ray, 12-lead ECG and arterial blood gas ABG sampling. Presentation. A key feature of the history is the speed of onset of breathlessness. Acute severe breathlessness over minutes or hours has a distinct differential diagnosis list to chronic exertional breathlessness. The presence of associated cardiovascular, chest pain, palpitations, sweating and nausea or respiratory cough, wheeze, hemoptysis, stridor symptoms can narrow the differential diagnosis yet further. A previous history of left ventricular dysfunction, asthma, or exacerbations of chronic obstructive pulmonary disease is important. A high temperature cough, productive or non-productive, and or viral prodrome may indicate respiratory infection, and if so, relevant infection control precautions should be taken from initial assessment. In the severely ill patient, it may be necessary to obtain the history from accompanying witnesses. In children, the possibility of inhalation of a foreign body or acute epiglottitis should always be considered. There is often more than one underlying diagnosis. A thorough assessment should continue even after a possible diagnosis has been reached, particularly if the severity of symptoms does not seem to be adequately explained. The causes of acute severe breathlessness are covered here. Chronic exertional dyspnea is discussed further on page 489. Oh, what is the clinical assessment that you will do for a breathlessness case? Airway obstruction, anaphylaxis, and tension pneumothorax require immediate identification and treatment. If any of these is suspected, treatment should not be delayed while additional investigations are performed and anesthetic support is likely to be required. In the absence of an immediately life-threatening cause, the following should be assessed and documented: level of consciousness, degree of central cyanosis, work of breathing rate, depth, pattern, use of accessory muscles, adequacy of oxygenation. Okay. Level of consciousness, degree of central cyanosis, work of breathing rate, depth, pattern, use of accessory muscles. So, these are some. This is the first image. It shows the X-ray. Second image, chest X-ray showing a tooth lodged in a main bronchoscopic appearance of inhaled foreign body. That is, so this is a picture of tooth with a covering mucus film. Ability to speak in single words or sentences. Cardiovascular status, heart rate, rhythm, blood pressure, and peripheral perfusion. Pulmonary edema is suggested by a raised jugular venous pressure and bibasal crackles or diffuse wheeze, while asthma or COPD is characterized by wheeze or prolonged expiration. A hyperresonant hemithorax with the absent breath sounds raises the possibility of pneumothorax, while severe breathlessness with normal breath sounds may indicate pulmonary embolism. Pulmonary edema is suggested by a raised jugular venous pressure and bibasal crackles or diffuse wheeze, while asthma or COPD is characterized by wheeze and prolonged expiration. A hyperresonant hemithorax with the absent breath sounds raises the possibility of pneumothorax, while severe breathlessness with normal breath sounds may indicate pulmonary embolism. Okay, where are we? Okay, prolonged expression. Okay, pulmonary edema is suggested. A hyperresonant hemithorax with the absent breath sounds raises the possibility of pneumothorax, while severe breathing with normal breath sounds may indicate pulmonary embolism. Leg swelling may suggest cardiac failure, or if asymmetrical, venous thrombosis. The presence of wheeze is not always indicative of bronchospasm. In acute heart failure, an increase in the left ventricular diastolic pressure causes the pressure in the left atrium, pulmonary veins, and pulmonary capillaries to rise. When the hydrostatic pressure of the pulmonary capillaries exceeds the oncotic pressure of plasma, about 25 to 30 mmHg, fluid moves from the capillaries into the interstitium. This stimulates respiration through a series of autonomic reflexes, producing rapid, shallow respiration, and congestion of the bronchial mucosa may cause wheeze, sometimes known as cardiac asthma. And the hydrostatic pressure of the pulmonary capillaries exceeds the oncotic pressure of plasma about 25 to 30 mmHg. Fluid moves from the capillaries into the interstitium. This stimulates respiration through a series of autonomic reflexes, producing rapid, shallow respiration and congestion of the bronchial mucosa. May cause wheeze, sometimes known as cardiac asthma. Sitting upright or standing may provide some relief by helping to reduce. Sitting upright or standing may provide some relief by helping to reduce congestion at the apices of the lungs. The patient may be unable to speak and is typically distressed, agitated, sweaty, and pale. Respiration is rapid with the recruitment of accessory muscles, coughing, and wheezing. Sputum may be profuse, frothy, and blood-streaked and pink. Sputum may be profuse, frothy, and blood-streaked or pink. Extensive crepitations and rhonchi are usually heard or audible in the chest pain, and there may also be signs of right heart failure. Okay, thank you so much.